Hi, I'm Dr. Evan Matthews. This is part 2 of the cardiovascular physiology section. In part 1, we went over the anatomy of the heart and some other information, a lot of definitions. In this part, we're going to be going over cardiac output, heart rate, and stroke volume, and how they intertwine with each other and what impacts those values. All right, so cardiac output is the amount of blood that is pumped by the heart each minute. All right, so it's usually quantified in liters per minute. And so if you look at this diagram here, we have the maximal oxygen consumption as a percentage of max. So here's the maximal amount of oxygen you can consume. So in other words, your peak aerobic ability, aerobic fitness. And on the left side of this, we have just rest. And here on the y-axis, we have the cardiac output in the liters per minute I just mentioned. So you can see that as oxygen consumption goes up, so does cardiac output. It goes up in this nice linear fashion. And so this is a really important relationship. Cardiac output is always going to be directly tied to oxygen consumption. So if oxygen consumption goes up, cardiac output has to go up too. So anytime oxygen consumption goes up, you should expect cardiac output to go up in a nice linear fashion with it. All right, so this is going to come back later on. We'll talk about this a lot more when we try to put all this together towards the end of this section. All right, so to talk a little bit more about cardiac output, besides aerobic fitness, which is, again, oxygen consumption, the other major determinant of cardiac output at max, so your maximal ability to pump out blood from your heart, is your body size. So a larger person has a larger heart, and so they can pump more blood. So the two things that come together to create cardiac output are heart rate and stroke volume. So cardiac output, which is often abbreviated as Q, equals heart rate times stroke volume. So heart rate is just the number of heartbeats per minute, and stroke volume is just the amount of blood pumped out of the heart with each of those heartbeats. The heart has its own ability to cause its own contraction. All right, so it stimulates itself. Unlike most of the body that's going to need to be stimulated by the central nervous system, the heart, even if it were to be removed from the body, will continue to pump for a period of time because it has its own, basically its own nervous system. All right, so you can see all these yellow wire-like structures inside the heart, and here it is again down here without the heart in the background. All right, so we have this conduction pathway or this conduction system within the heart that is going to cause this spontaneous rhythmicity. All right, so that just means that it is going to contract on a regular basis. All right, and that contraction has got a lot of different things that control its rate and its speed, and we'll talk about that in the next slide or two. The SA node is this bundle of cells right here, also being depicted on top of the heart's image right here. So the importance of the SA node is that is where the contraction of the heart starts, at least in a normal, healthy heart. So I mentioned that the SA node is the spot where the electrical signal starts. That electrical signal is an action potential. So if you don't remember what I mean by that, go back and watch the nervous system chapter. And so the action potential starts here, spreads throughout these internodal pathways that go through the right and left atrium, come back together to the AV node, which is the only spot where the top and the bottom of the heart is connected electrically. And then it's going to pause for a little while, and we'll talk about that more later. And then it's going to spread through the bundle his, through the right and left bundle branches, which are these two splits here, and then through the Purkinje fibers to the individual cells of the heart. Now, the signal also has the ability to be conducted from cell to cell of the myocytes, so the actual muscle contracting the heart. So even if there is not one of these sort of electrical cells immediately next to a certain cardiocyte, it's still going to eventually be stimulated by one of its neighbors. So again, the electrical pathway can, or the electrical signal can go through the pathways, or it can go from cell to cell. It just takes a lot longer. That's why we need to have these pathways to sort of speed up the conduction. An electrocardiogram is essentially a representation of electrical activity of the heart. So we do this by putting a bunch of sticker electrodes on the chest of the individual, and the computer attached to those electrodes is going to combine all the signals together into something that looks like this. So it looks a lot different from an action potential, because essentially what we're seeing is many hundreds and thousands of action potentials all sort of crammed together in this signal. So it doesn't look like a normal action potential like what we covered in the neural control section. All right, so each of these little bumps and peaks means something though. All right, so we have the P wave, we have the Q, the R, and the S wave, and then we have the T wave. And then we have these various segments and intervals that are between and including some of these waves. All right, so a segment is between waves, an interval is the space between waves and at least one wave. All right, so the P wave, let's start at the beginning. So the P wave is atrial depolarization. All right, so remember, muscle only contracts when a electrical signal tells it to contract. So in the heart, it's going to not necessarily come from a neuron, it's going to come from that electrical pathway inside the heart. All right, so the P wave, again, is atrial depolarization. Depolarization is what's going to initiate the contraction of the heart. If you go back also again and look at the neural control section or the nervous system section, when we talked about depolarization, then it was usually followed immediately up by repolarization. So in order to have this happen over and over again, so this here is one heartbeat. Here is another heartbeat. So in order for have that second heartbeat, and we have heartbeats constantly, in order for that to occur, we have to repolarize after this depolarization. So again, the P wave is atrial depolarization, so you're losing the polarization. The repolarization wave is somewhere in here. Because of this big structure, which I'll talk about in a second, it kind of gets buried, we don't see it. But atrial contraction starts when the depolarization begins. So right here at the beginning of this sort of PR interval, that is the beginning of atrial contraction. Atrial contraction ends when the atriums repolarize, which again happens somewhere about here in the middle of what's called the QRS complex. All right, so that is atrial depolarization and then repolarization. So that entire period between depolarization and repolarization is atrial contraction. The QRS complex, so QRS, together those three waves are called the QRS complex. That is ventricular depolarization. So again, the P wave is atrial depolarization. The QRS complex here is ventricular depolarization. So this is going to be what initiates the contraction of the muscle in the ventricles, so the bottom part of the heart. So contraction is going to start around here, and it's going to end at the end of repolarization. All right, so for the ventricles, we can see repolarization. It is this T wave right here. So the T wave is the repolarization. The QRS complex was the depolarization. So contraction starts with depolarization right in here and goes all the way through this, still contracting, and ends at the end of the T wave. All right, so because we know where contraction is happening and we can see how it's happening essentially with this electricity, this electrical signal, it allows us to look for abnormalities of the heart. All right, so we're not going to really go over those here. It can get very in-depth, and this requires a course all to itself and potentially multiple courses and lots of practice and experience to be good at this. But each of these waves, each of these segments, they all represent something. And not only do they represent something, but they can be altered in certain abnormal heart rhythms. And we can figure out what those abnormal heart rhythms are because we know what they look like on an electrocardiogram or ECG. Also, just a side note, if you see EKG out there somewhere, an EKG and an ECG are the same thing. It's just two different abbreviations from essentially different parts of the world that have kind of come together and people use them side by side. All right, so again, the SA node is where the signal to contract starts, but then eventually it goes to this AV node. And I said before briefly that it slows down there, and it's important that it slows down there, and that's actually what is being represented here by this PR segment. This is the pause that's happening when the electrical signal gets to this AV node. And that pause at the AV node is very important because it's going to allow time from for the blood that's in the top of the heart and these right and left atriums to get into the bottom of the heart, the right and left ventricle. All right, if you didn't have that pause, if the atriums and the ventricles contracted at the same time together, then you wouldn't have this flow of blood from from the atriums to the ventricles, and then the same flow of blood out of the heart to the body. The blood would kind of just sit in there, and it wouldn't be able to move around the way it's supposed to. So you need to have this pause at the AV node. It's very important. Even though the heart has the ability to contract, to cause its own electrical signal in order to contract, there are outside influences that are going to change how it contracts, or I should say the rate of its contraction, in other words, the heart rate. Right, so the heart rate is going to be altered by both parasympathetic activity and sympathetic activity. So these are the two branches of the autonomic nervous system. Parasympathetic activity is going to be feeding onto the SA node, so it's dumping acetylcholine onto the SA node, and it's going to cause the heart rate to slow down. All right, on the other side of things, sympathetic activity is going to be also innervating the SA node, and it's going to be dumping norepinephrine onto the SA node, and that's going to accelerate the heart rate, so it's going to speed up the heart rate. All right, so again, we have parasympathetic activity trying to slow the heart rate down, and we have sympathetic activity trying to speed the heart rate up. And they're both constantly on. It's just whether the heart's high or low in its speed is going to be which one is more dominant at the moment. All right, so if we were to remove all autonomic nervous system activity on the heart, so let's say, for instance, somebody got a heart transplant. All right, so if you had a heart transplant, for the initial weeks to months after that heart transplant, before the autonomic nervous system neurons can grow back into your new heart, there will not be innervation by either the parasympathetic or sympathetic nervous system. Because there's no innervation by the sympathetic or parasympathetic nervous system, you're going to have the intrinsic rate of the heart just come out. All right. So in other words, it's going to be at the rate it wants to because there's no influence from anything on the outside telling you what to do. All right. So the intrinsic rate of the heart is 100 beats per minute. Right, so if the heart rate is below 100 beats per minute, that means you have parasympathetic drive slowing the heart rate down. If the heart rate is above 100 beats per minute, like it oftentimes is with exercise, that means you have sympathetic nervous system activity driving the heart rate up. All right, so at rest, we have a lot of parasympathetic tone, which is why most people's heart rate at rest is somewhere between 60 and 90 beats per minute. And during exercise, most people's heart rates are well above 100, maybe up to 200 plus beats per minute. And the reason for that, again, is because we have a strong sympathetic drive. We have maximal oxygen consumption from rest all the way up to peak aerobic exercise. And then we have heart rate at 0, which doesn't happen in a living person. Obviously, it's going to start somewhere around 60 to 90, so somewhere around here, and go all the way up to about 200 beats per minute. All right, so we have this nice linear relationship. You look at the black line here, where as oxygen consumption goes up, the heart rate also goes up. All right, so when the heart rate, so when this black line is below this dotted line here, which is the 100 beats per minute, that means you have a lot of parasympathetic activity. When it is above it, you have a lot of sympathetic activity. So again, parasympathetic and sympathetic activity are always on. It's just which one is more dominant, which one is sort of an overdrive or not at the moment. And you can also think about this the opposite way. So at rest, you have a lot of parasympathetic activity, and it's taking the heart rate from 100 down to, say, 60. And if you were to withdraw that parasympathetic activity, so in other words, if you were to remove some of that parasympathetic activity, the heart rate would actually go up. Right, so just like you can slow it down by turning on parasympathetic activity, you can actually speed up the heart rate up to at least 100 beats per minute by simply removing some of that parasympathetic activity. Likewise, if you're above 100, that's because you have a lot of sympathetic activity, and if you withdraw some of that sympathetic activity, the heart rate's going to come back down a little bit. All right, so where the heart rate is above or below the 100 line there, so 100 beats per minute, is going to let you know if you have a lot of sympathetic or a lot of parasympathetic activity. At rest, mostly parasympathetic. During exercise, mostly sympathetic activity. So as already mentioned, heart rate's going to increase linearly as your aerobic exercise intensity goes up. And it's going to do that all the way until you get to your maximal heart rate. So everybody has a different maximal heart rates. It is important to note that it is not determined by your fitness level. So your maximum heart rate doesn't go up because you become more fit. The one thing that really determines your maximum heart rate is going to be your age. All right, so if you are 20 years old, your maximum heart rate is probably going to be around 200 beats per minute. If you are 40 years old, it's probably going to be around 180 beats per minute. And the reason why I know that is we've had these estimate-based equations to estimate someone's maximum heart rate, and the most common one is 220 minus your age. All right, so we also have some other ones out there. There's several of these. Another one is 208 minus 0.7 times your age, and there's several that look a lot like this. These ones are typically a little bit more accurate, but 220 minus your age is very easy to remember, very easy to calculate, and it's pretty close. Both of these equations are probably going to have a plus or minus about 10 beats per minute to actually get to whatever their actual heart rate is. So just because your estimate is, say, 200 doesn't mean that's your true max. Right? The only way to know a person's true maximal heart rate is to simply get them to exercise all the way to their maximum aerobic ability and to measure their heart rate. So an estimate is never going to be as good as a measurement, but they're pretty good and they work for most people. So stroke volume is going to also increase as aerobic exercise intensity goes up. The difference here, though, is so it starts off linear just like cardiac output and just like heart rate did, but somewhere around 40 to 60% of your VO2 max, it's going to start to level off a little bit. And so unlike those other two that go up almost until max, again, this is going to level off around half to a little beyond half of your maximal ability. And so this is something that is going to occur in almost everybody, but there are some exceptions. The main exception is if you get an elite endurance athlete, this slope change is probably not going to happen until a little bit later, say maybe 70 or 80% of their maximum ability, and it's probably going to still be fairly steep. They're going to increase stroke volume most of the way to their max. But this is only the most elite of endurance athletes. All right, so some other things that are going to affect stroke volume, we're going to talk about a lot of them, but a couple of simple ones here. If you were to look at stroke volume does increase a lot though with exercise. So if you look at maximum stroke volume max, it's going to be about double what it is when you're standing up. Right, so if you're standing up, you measure your stroke volume, and then you exercise all the way to your maximum aerobic ability, so up to 100% on this scale, it's going to be about double what it was at rest. And of course, that varies depending on the person and their fitness level. However, if you were to look at that person when they're supine, in other words, laying on their back, and you measure their stroke volume then, and then compare that to their maximal ability, there's not going to be a big difference. Right? So the reason for this is when you're standing up, gravity's working against your heart, making it harder to pump blood out of your heart, and so you're going to have a much lower stroke volume when you're standing. That's the reason why when you're standing, it's got a long way to go until you get to your maximum stroke volume. If you are doing some sort of supine exercise like recumbent cycling or swimming where you're horizontal, you'll see that stroke volume at rest isn't that different from stroke volume at your maximum ability. It still goes up, just not nearly as much. So let's talk about some of the determinants of stroke volume. There's a lot of things at play here. All right, so the big ones are your end diastolic volume, your contractility of your heart, so how hard your heart is beating, and your afterload. All right, so end diastolic volume being depicted here is the amount of blood inside your heart right before it contracts. So diastole, end diastolic means at the end of the relaxation phase of the heart and right before the systolic or contraction phase of the heart. So right before the heart beats, the preload, how much blood is in the heart, that end diastolic volume. If there's more blood in the heart, more blood can be pumped out of the heart. All right, so basically if you have more of a liquid in a container and then you empty that container, you're going to empty out more liquid. So it's pretty obvious, I think. There are some other mechanisms, though, that also cause a greater stroke volume with a greater end diastolic volume. The main one that I want to talk about here is something called the Frank-Starling mechanism. The Frank-Starling mechanism basically means the more you stretch the muscle fibers of the heart. So as this blood is pushing out on the left ventricular chamber here, stretching those muscle fibers, the cardiac muscle fibers, it's going to cause a greater contractility of the heart. So it's going to add to this here. It's going to increase the contractility of the heart. And the reason for this is what's being depicted down here. So if you look back in the muscle chapter set that we covered in another video, you'll see that there's an optimal actin and myosin overlap. So the actin and myosin are the two proteins in the muscle that cause contraction. All right, so if you have too much overlap, so if the actin starts going past each other, there's very few places where myosin can grab on and pull. So if you can't grab on and pull with as many places, you can't produce as much force. If you're talking about the heart, that means contractility is going to be lower. In most people at rest, they're working at a very overlapped position. So their actin, their myosin, they're way too close, there's way too much overlap, and they're past each other to the point where you're not getting very much of the actin and myosin binding to each other. And so that means low contractility. So when you have low stretch to the heart, you have low contractility. If you add more blood into the heart and you stretch the heart more, you're spreading out those muscle fibers, and you're going to get something more like this, where you have a more optimal overlap of actin and myosin. There's more places for the actin and myosin to grab onto each other and pull, which means you can produce more force, increasing contractility. If you increase how hard the heart is beating or how hard it's contracting in on itself, you're going to increase how much blood can be pushed out of it, right? So that is what the Frank-Starling mechanism is. The more you stretch the heart, the harder it beats in, the more harder it contracts in, the more blood can come out of the heart. All right, so that is basically the end diastolic volume. Again, more end diastolic volume means greater stroke volume. All right, so on to number 2 here, contractility. So how hard the heart is contracting in on itself. Kind of already talked about this a little bit, but if you were to increase sympathetic activity, not only is it going to increase heart rate by stimulating the SA node, it's also going to stimulate a lot of the other areas of the heart, causing the actual muscle cells to contract harder. All right, so an increase in sympathetic activity is going to increase contractility, which just means how hard the heart squeezes in on itself. If you squeeze in on yourself, if it squeezes in on itself more, that means it's pushing on the blood that's inside of it harder, and that means it's going to inject more blood. So again, stroke volume will be higher with higher contractility. So while having a greater end diastolic volume, increased stroke volume, also having a greater contractility of the left ventricle is going to lead to a greater stroke volume. Having a greater afterload is going to lead to a lesser stroke volume. All right, so afterload is the pressure pushing back at the heart from the aorta and the peripheral peripheral vascular system. So it is the blood pushing back towards the heart as the blood is trying to be ejected out the other way. All right, so if you have more pressure pushing back, obviously it's pushing against what you're trying to go this way, it's pushing this way, and they're going to oppose each other. So having a greater afterload is going to lower stroke volume. So let's take some time and let's come back to end diastolic volume. All right, so remember, greater end diastolic volume is going to lead to a greater stroke volume, but there are lots of things that can lead to a greater end diastolic volume. So let's talk about some of those. So if you have greater venous return, you're going to have a greater end diastolic volume. So venous return is the term we use for the blood getting back from the venous side of the circulation to the heart. All right, so in other words, how much blood is coming through the inferior and superior vena cava. All right, so one way that we have the ability to increase venous return is by increasing the sympathetic nervous activity to the veins. All right, the veins have smooth muscle in them, similar to what is in the arterioles on the arterial side of things. So the arterioles can constrict, so can the veins. The veins can constrict. And when they constrict, they push blood out of themselves and into the heart, adding more blood to the arterial side of circulation. All right, so at rest, about 2/3 of the blood is actually in the veins. So the veins actually serve as kind of a reservoir for blood in the body. That, again, 2/3 of the blood is in those veins, and so if you constrict them, you're going to have more blood for the heart and the arterial side of circulation. All right, so two other things that are going to add to venous return are the skeletal muscle pump and the respiratory pump. And we're going to talk about each of those on the next couple slides. So let's go ahead and just get to them. All right, so this is a diagram of the skeletal muscle pump. All right, so if you think of this as a vein going in between your muscle, all right, so you have veins and arteries that go directly through your muscle. So if you think of this as like your quadricep in your leg, and you have a big muscle there with lots of veins going through them, those veins are going to have blood in them. Again, I just mentioned 2/3 of your blood at rest is in your veins. All right, so one of the unique characteristics of veins is they have these valves in them. These are one-way valves similar to what's inside the heart. So if you contract the muscles around the vein, kind of like what's being shown here, it's going to put pressure on that vein, constricting it inward, pushing on the blood, and that's going to cause the blood to move forward. The reason why it moves forward, again, is because we have these one-way valves that prevent it from moving backwards. So if you're pushing in on the vein, the blood only has one direction to go, and that's forward towards the heart, adding to venous return. So basically, you constrict the muscles in, you squeeze the space, blood comes out, and then you relax the muscle, and that allows it to come back to its sort of rested position that's not constricted, and so blood flow can come back into it, it refills with blood, and then you're back to the beginning where it can just start again. So this is something that's really important for exercise. It's also important for walking. All right, so if you've ever heard of the sort of stereotype of being at a military graduation or a police academy graduation and people passing out because they're standing at attention, that is because they are standing with their knees and all their muscles in their lower limbs locked. All right, so they're not allowing those muscles to contract and relax, which is what normally when people stand, they kind of shift back and forth. They use one leg more than they use the other leg more, and so they have this sort of, it might be slow, but they have this muscle pump, the skeletal muscle pump, acting all the time, where they're relaxed and they contract and they're relaxed again. And so again, it's getting blood out of the legs and into the central cardiovascular system. So by that I mean the heart. If you stand at attention for a long period of time and you contract your legs like this and you don't relax, so if you stop here and you don't relax, so you don't get back to this stage where you relax, it means the blood is going to just stop flowing, right? The veins of the lower legs will fill with blood, and that means less blood is getting back to the central parts of the body, so back to the heart. And if there's less blood getting back to the heart, that means less blood is getting back to the brain. So that's why a lot of people at military type graduations will black out and fall over, and they'll come to right away afterwards, because as soon as you fall over, gravity is now working for your heart, bringing blood back to the heart rather than against it. And so the skeletal muscle pump is very important for returning blood from the exterior of the body, so the periphery, the lower limbs especially, back towards the heart. All right, so that's the skeletal muscle pump. Again, just the muscle squeezing on the vein, pushing blood out of the vein and towards the heart. The respiratory pump has some similarities, but it's a little bit more complicated. One interesting thing is the respiratory pump is both going to bring blood to the heart, as well as this is the mechanism that allows us to ventilate our lungs, so breathing air in and out of our lungs. All right, so if you look at this diagram here of the respiratory pump, this is essentially a cross-section of the human body. So if you were to split me in half and open me up so you can see the side of my ribs as well as this, so this would be the side of the ribs as well as the side of the spine. And this is the lung, and in the background here we can see the heart and we can see the superior and inferior vena cava. All right, so we also have the diaphragm here, and we have all the intercostal muscles being displayed. All right, so the intercostal muscles, so the diaphragm, this muscle right here, is this dome-shaped muscle when it's relaxed, and when it contracts, it sort of flattens itself down. That's what's being shown here, is the diaphragm flattening itself down, and when it does that, it makes the thoracic cavity bigger. All right, so when the thoracic cavity gets bigger, what's going to happen is there's going to be a decreased pressure inside the thoracic cavity. This is something that happens very quickly, and when you have a decrease in pressure, you're going to have sort of suction, right? So if you think of it like sucking on a straw, it's going to suck the blood in, both from the inferior vena cava to the right atrium and the superior vena cava to the right atrium. This is also what sucks the air in from the outside of your body through your mouth and nose into your lungs. So it's sucking the air in, and then what we're going to do is we're going to relax that diaphragm back to its resting dome-like shape, and that's going to increase the pressure inside the thoracic cavity. And so during that period of time, you're going to have expiration of the air from your lungs to the environment. You're also going to have a period of decrease of venous return. So you can see that we went from 2 red arrows to only 1 red arrow here. So there's less blood getting back through those inferior and superior vena cava and back to the heart. So every time you breathe, you have a period of lots of suction, so blood coming in periods where there's less suction or maybe even a little higher pressure causing less blood to come in. So there's still blood coming in no matter where you are in the respiratory cycle, but there's more blood being sucked into the heart during this phase where you contracted the diaphragm than this phase where you relaxed the diaphragm. And so you basically end up with this cycling pattern where you have more blood coming into the heart, less blood coming into the heart, more blood coming in the heart, less blood coming in the heart. And so that's all linked to your breathing. All right, so let's put all this together. All right, so we have a couple different things happening on this diagram. So we have an untrained person and a trained person at rest or at submaximal aerobic exercise. So they are at the same submaximal aerobic exercise. So in other words, this is either 2 people just sitting down doing nothing, so that's resting, or it's 2 people, say, getting on a treadmill running at 5 miles per hour, but they're both at 5 miles per hour. So it's either rest or matched submaximal aerobic exercise workloads. Then over here, we have the same untrained and trained individual at maximal aerobic exercise. So they're working as hard as they possibly can on that treadmill. So let's come over here first and let's kind of work this out and figure out how all this is connected. All right, so if you remember back, I said cardiac output, so this Q, is always going to be directly linked to oxygen consumption, which is VO2. All right, so if your VO2 is here, your cardiac output has to be here as well in order to match that, because you can't extract oxygen out of your blood if there isn't blood there. So again, the cardiac output always matches what the VO2 needs as long as the body is capable of it, which it is capable at rest and at submaximal levels of doing that. All right, so you can see because they're both working at the same exercise intensity, whether you're untrained and unfit or trained and very fit, you need about the same amount of oxygen in order to do the same work. So again, if they're both running at 5 miles per hour, they both need the same amount of oxygen to do that approximately. And so they both need about the same amount of cardiac output in order to meet that oxygen demand. The difference between the trained here and the untrained person is how they meet that. So remember, cardiac output equals heart rate times stroke volume. All right, so we have heart rate and we have stroke volume, and then over here, trained person, heart rate, and stroke volume. So the difference here is the trained individual has a very, very high stroke volume level. And because they have a very high stroke volume level, they can have a very low heart rate. Right? Heart rate's always going to compensate for what stroke volume cannot do in order to get to cardiac output. So if stroke volume is very, very capable, so a trained individual is going to have a really big heart, really big ventricles, so it's going to be able to bring in lots of blood, so have a really high end diastolic volume and pump out lots of blood with each heartbeat. So again, they're going to have a very high stroke volume compared to the untrained person, which means they can have a very low heart rate compared to the untrained person. So their stroke volume is going to be higher than the untrained person at every level of rest through submaximal exercise, and their heart rate is going to be lower at every level from rest through submaximal exercise. All right, so that is the difference between an untrained and a trained person, again, either at rest or match submaximal workloads where they're both at the exact same level. If we come over here to the maximal workloads, so this is, you get them on the treadmill, you have them run, you make the treadmill go faster and faster and faster until they can't go anymore and they have to stop. All right, so the trained person is going to be able to go further and harder than the untrained person. All right, so that's a key difference here. So we're over here, we had matched workloads. They were working at the exact same intensity. We assigned them both 5 miles per hour on that treadmill. Over here, this person's maybe running at 10 miles per hour, where this person's running at 7 miles per hour. So they're not working at the same exercise intensity anymore. It's the same relative intensity. They're both working at their maximal ability, but the absolute intensities are different. This person, the trained person, is going to be working harder than this person, the untrained person. Because this person is working harder, they need more oxygen in order to support that workload. That means they need more cardiac output. Where over here, less oxygen is needed to support that workload and less cardiac output is needed. Now, the reason why we're going to have a higher workload over here is because the trained person can have greater cardiac output. So it's not like the trained person's cardiac output's at its max and the untrained person's not. It's not that at all. Both of them, their cardiac output is doing as much as they possibly can, and this just happens to be the amount of oxygen consumption they can work at their maximal cardiac output. So it's kind of the other way around. So again, at submaximal workloads, the cardiac output matches what's required for the oxygen consumption, but at maximal workloads, the oxygen consumption is going to be determined by the cardiac output, and the level of exercise performed is also going to be determined by the level of cardiac output possible. So if you can pump more blood out of your heart, you're going to be able to work at a higher intensity. All right, so again, we have some differences with how they get to those cardiac outputs too. So notice that both of them have about the same heart rate at maximal exercise. So remember, the primary determinant of heart rate at maximal exercise is not fitness level, it's age. All right, so assuming these people were about the same age, they're going to have about the same heart rate at max levels of exercise. Now, one small nuance that I don't expect most people to remember or even care that much about is a trained person actually has slightly lower maximal heart rates than an untrained person, just because they have a stronger parasympathetic drive that kind of suppresses their heart rate. But we're talking about a couple beats per minute, something that's basically negligible. But for our purposes, let's just say the heart rate at max is the same. Let's say they're both 20 years old, so they're both going to have a heart rate max around 200 beats per minute. The big difference here comes with stroke volume. Notice how high this stroke volume is and how low this stroke volume is. All right, the trained individual has a really, really high stroke volume. The untrained individual has a very low stroke volume. So if you go to calculate cardiac output, remember it's heart rate times stroke volume. So if you have the same heart rate, but this person has a higher stroke volume than this person, you're going to end up with a higher cardiac output with the person with the higher stroke volume. So basically what all this means is the trained person has a higher stroke volume that they're capable of. Because they have a higher stroke volume that they can reach, they can have a higher cardiac output. because they can have a higher cardiac output, they can reach a higher VO2, so a higher amount of oxygen consumed. Because they have a higher oxygen consumed, they can then work at a higher exercise intensity, which is why this person's working at 10 miles per hour and this person's working at 7 miles per hour. All right, so some differences, again, big differences between maximal aerobic exercise and submaximal aerobic exercise that's at a matched exercise intensity. All right, so you always have to know whether it's a matched exercise intensity or at maximal exercise if you're trying to figure out whose heart rate's going to be higher, whose stroke volume is going to be higher, whose cardiac output's going to be higher. Again, at maximal levels, the trained person is going to have a higher cardiac output, a higher stroke volume, but approximately the same heart rates. At submaximal exercise loads that are matched between these two people, the cardiac outputs are going to be the same, the VO2s are going to be the same, the stroke volume is going to be higher in the untrained, and the heart rate's going to be lower in the untrained. The stroke volume is going to be higher in the trained, and the heart rates are going to be lower in the trained individual. All right, so spend some time on this. I know that's a lot of information I threw out on this one diagram, but if that all makes sense, if you can sort of fit these pieces all together in your head, I think a lot of this is going to become much more obvious to you, and it won't feel like you're memorizing material. It'll feel more intuitive to you. All right, so that is the end of section 2 of the cardiovascular section here. So again, section 1 was basically anatomy. Section 2 was how cardiac output, heart rate, and stroke volume are determined and how they interact with each other. So spend some time thinking about each of these before you go to section 3, because it's going to get a little bit more in depth. We're going to hit blood pressure, and we're also going to hit how blood flow is kind of controlled in the body. So it's going to be a little bit more level of depth than what we've covered so far. So if you have any questions or comments, please put those in the comment section below, and I'll try to get back to you. Otherwise, please come back and watch another video. Thanks.